just a straight up disclaimer, a lot of my information, a lot of my resources are from the St. Luke's guidelines. They're excellent guidelines. If you're not familiar with the guidelines, I strongly recommend looking them up. They're updated pretty much on a monthly basis, and the most recent update was done about 2 weeks ago. And so if you're ever stuck for resources, I'd recommend looking that up. So what we're going to try and do is spend most of our time on the non-small cell lung cancer. I split that into updates in radical or adjuvant setting, followed by the palliative setting. I've given a brief one-liner on the latest trials that came out of ASCO 2020, and then how COVID-19 has amended our pathways and our protocols. I'll do something similar for small cell lung cancer, and then I'll just touch on mesothelioma and thymoma. So it's literally a slide each on those. There haven't been many updates at all, if any, in those latter, but we'll go through the standard processes just so that you know what to do if you come across them in clinics.
Waleed, are you able to make it a slide to screen bigger?
Does that work?
Yeah, perfect.
Okay, perfect. So hopefully you can see that a bit better now. So that's the contents, and we'll work through each of those in turn. This is the main slide. If there's a takeaway slide that, and you're preparing for exams and there's a takeaway slide you need, I can't recommend this slide enough. Essentially, all you need to do is to look up your TNM and memorize them. You need to be more than familiar with them, because based on your TNM classification, you can come up with your staging system. And based on the staging system, you have a summary of what the management plan should be. Can you guys see the pointer if I move that around? Okay, I'll assume you can. Questions exams ask are often based on the management plan, based on your TNM staging. So you need to be able to read a STEM, classify the TNM, work out the stage, and come up with a management plan. And this table can be quite tricky to learn. So all I'll say is, if you just notice that T3, N2 is staged as 3B, anything equal to or above that cannot be treated with surgery. So anything down this way is treated with chemoradiotherapy. Anything that's up this way is treated with surgery. So to summarize that over here, radical treatments for stage 1 and stage 2. These are predominantly treated surgically. If there's lymph node positive disease or the disease is greater than 4 centimeters IT2B, you then offer them adjuvant chemotherapy. And if surgery is not indicated, equal cure rates are achieved with SABR, less with radiotherapy, and radiofrequency ablation has the lowest cure rate. So look at the stage. If it's radical, you're trying to get for surgery. 3A and B, we're looking for surgery or chemoradiotherapy. And if we're going for the chemoradiotherapy, we want the concurrent treatment over the sequential treatment, provided patient is fit enough and provided the disease is localized. And this stage 4 is all treated with systemic treatment. So we're going to focus on most of these in the next few slides, not on these. There's been very little updates on this. Most of the updates have been here. Before we go on to the palliative, the only thing we need to talk about in the radical setting or in the adjuvant setting with non-small cell lung cancer came out of the Pacific trial 3 years ago. And this tested adjuvant durvalumab versus placebo in patients who had stage 3 non-small cell lung cancer, and that could have been an adeno or a squamous cell cancer if these patients, following concurrent chemoradiotherapy, it was not sequential, it was concurrent chemoradiotherapy, if they had partial response or stable disease with a PD-L1 score of greater than or equal to 1%, so it cannot be 0%, it has to be greater than or equal to 1%. These patients went on to 10 milligram per kilogram of durvalumab, and they had it 2 weekly for up to 12 months. And the median progression-free survival jumped by about 3 times, so from about 5 months to about 15 months. And the biggest issues in terms of toxicity were grade 3 to 4 pneumonia in less than 5% of patients. In our experience at Charing Cross, we're a bit anxious about starting durvalumab only because our last 2 patients who had it actually ended up in intensive care unit with pneumonitis, and one of the 2 patients died. So you have to consent people very carefully before you start the durvalumab. Okay, so that's the main update that's come out of your adjuvant or radical setting non-small cell lung cancer. Everything else has mainly come out of your palliative or stage 4 setting. And again, the highlight of the story, or the main headline, is just it's immunotherapy or your tyrosine kinase inhibitors. So at MDT, you must insist on getting all 4 of these immunohistochemistry results back before you can offer any sensible opinions. Some of them can take a few weeks to get back, so it's important that you have a clear plan of what you're doing before you decide a management plan, because you're either going to go for your oral TKIs or you're going to go for a combination of chemo immunotherapy triplet. I hope some of you have seen this table before, or this flowchart again. So the next 4 flowcharts are directly lifted from the St. Luke's Guidelines website. This one hasn't been updated in a few months, but there's not been anything to update it. It's the busiest of the 4 sort of algorithms, and it's looking at non-squamous non-small cell lung cancer. So these are purely the adenocarcinomas who are in stage 4. Provided they have ALK negative, EGFR negative, and ROS1 negative on the immunohistochemistry, they're going to fall under one of these 3 arms. The majority of people that we see are what we call, they're equivalent of triple negatives in the breast cancers, but they're ALK and EGFR wild type, and they have a PD-L1 score of less than 50%. So these people are by far the most common group of people that we get to, and they're treated with triplet pemetrexed, cisplatin, and pembrolizumab immunotherapy. And they can go on to the maintenance pembrolizumab and pemetrexed after the 4 cycles if they have stable disease or partial response. And then those 2 P drugs can carry on for up to a maximum of 2 years, or until side effects, or until progressive disease. After that, if they progress, the next line treatment is the final standard line treatment, and that's docetaxel nintedanib. Nintedanib is only given in the adeno setting. That's another exam question that comes up. It's not an option in squames, and we'll look at that on the next slide. So the problem with this arm is highlighted when we compare it to the other arm. So the pembrolizumab monotherapy. If a patient has a high PD-L1 tumor proportion score of greater than 50%, you have the option of giving them either the same triplet or the pembrolizumab monotherapy. This is often given to people who have small volume disease, and this is given to people who need a much more rapid onset of response because of the chemotherapy component. However, the advantage of the monotherapy is that you've actually split this triplet treatment arm, or this triplet treatment options, into 2 subsequent lines of therapy. So you're getting more bang for your buck, and you have to run through a few of these before you end up on your final stage of docetaxel nintedanib. Finally, if patients are not suitable for their immunotherapy, you can just start them off on the standard, or this was the pre-immunotherapy standard, pemetrexed carboplatin, followed by the maintenance pemetrexed, and then consider your immunotherapy if they then become fit for it. Remember, they were not fit for it originally. The advantage of a atezolizumab over pembrolizumab is that you do not need a PD-L1 status on there, so most people tend to go for this. Okay, we very rarely go for vinorelbine monotherapy, because if someone's over the age of 70 and they're not fit for doublet, you really have to question what you're going to achieve with the single agent vinorelbine. Moving on to the squamous cell cancer, something very similar. The majority of people have the pembrolizumab carbotaxol, and if they progress on that, it's docetaxel. Remember, there's no nintedanib option. Some people who are highly PD-L1 positive go on the pembrolizumab monotherapy, and people who are unsuitable or who are negative can just go for your gem carbo standard, which is what we tend to use over here. And if they then become fit for whatever reason, you have three options. Nivolumab and atezolizumab have no PD-L1, and pembrolizumab, you need to have the score. This is actually important. You need blue tech registration, and they specifically ask you the PD-L1 score, so you have to have this information at MDT, as we mentioned. Docetaxel or docetaxel and nintedanib for the adenocarcinoma response rate is less than 10%, so you have to very carefully consent patients before you start them on. A few years ago, we switched from first-line Tarceva to the afatinib treatment. What I can do afterwards is send you a list of all the papers that actually decided our first-line treatments, but again, as I said, this is more of a process-based talk. If people start off with afatinib on adenocarcinomas that are EGFR positive, they can then progress, and you test the TCF90 mutation, and osimertinib is the newer drug that's come about. If they progress on the osimertinib, then you can go on to chemotherapy followed by immunotherapy. And the important point here is that the immunotherapy comes at the end. So it's TKIs followed by chemotherapy, followed by immunotherapy at the end, which is slightly counterintuitive, but I'll explain why that is on the next slide. At Charing Cross and at a lot of other centers, we are now going for quadruple therapy, and I'll talk a bit about that later on. Essentially, it's a much more aggressive, time-consuming treatment, but the median overall survival is about 30 months compared to about 5 months. And this was presented at the Empower 150 results study recently. So if your center supports this regimen, go for that, and we're doing that over here. Other centers are as well. And finally, on the non-small cell lung cancer ALK positive groups, again, the first line treatment is alectinib. They're easy to remember. So for the EGFR positive, it's afatinib, begins with A, alectinib begins with A, so it's the first letter of the alphabet. If they progress, lorlatinib has come on scene from this year, and if they progress on that, you then go on to the pemetrexed, cisplatin, followed by maintenance and immunotherapy again at the end. Some patients who have been on treatment for a while would not have had the opportunity to go on to alectinib. They would have been on ceritinib, crizotinib, and then they have these alternate pathways to end up on the chemotherapy and immunotherapy. But again, the quadruple treatment is an option over here. So those are the standard pathways. I'll send you papers for how we got to those standard pathways, but it's important, or it's useful just to have that feedback, the framework for you to work off. The newest thing from the non-small cell lung cancer was in ASCO this year, the ADARA study, which looked at stage 1 to 3A, so radically treatable adenocarcinomas who were EGFR mutated and underwent surgery. These patients, who ordinarily would have been watch or wait or adjuvant chemotherapy if they were greater than 4 centimeters or lymph node positive, they then randomized them to placebo or adjuvant osimertinib at 80 milligrams once a day for 3 years. And the 2-year disease-free survival was staggering, so it doubled, from 44% to 90%. This is not standard of care yet, but this will be soon, I imagine.
Waleed, you've got 5 minutes.
Thank you. And just to finish off on the COVID amendments to our treatments, durvalumab can now be extended to 4 weekly instead of 2 weekly. Pembroke be extended to 6 weekly instead of 4 weekly. And we have monotherapy option instead of the triplet. We can also give first-line osimertinib instead of the other TKIs, and we're omitting regimens with the day 8. Okay, that was the biggest part of the talk. It's the non-small cell lung cancers. The rest of the talk we'll be able to breeze through in a few minutes. Just a quick question on, just a quick pointer on EGFR and ALKs. If you've got both this mutation and a high PD-L1 status, you always go for the EGFR treatment because that's a driver mutation. People who have these mutations are younger, they're non-smokers, they haven't had years of acquiring somatic mutations through smoking, so this tends to work poorly. That's why immunotherapy comes after the chemotherapy in this treatment. And virtually no patients have both of these, but you can sometimes get combined EGFR and ALK mutations, and there's insufficient data in what to treat them with, and most people go for the ALK over the EGFR, but again, insufficient data. In terms of the small cell lung cancers, you all should know the standard palliative treatment, which is 6 lots of E-carbo, followed by radiotherapy, followed by PCI, and the second line treatments. The new option is from the Empower study. So this was published about 2 years ago, and NICE has funded it this year. We give 4 cycles of etoposide carboplatin, and we add atezolizumab, which can then be continued as a maintenance with a very modest progression-free survival of a month, an overall survival of 12 months rather than 10 months. But the disadvantage to this treatment is because you're on maintenance atezo, you cannot then go on to radiotherapy and PCI. And with COVID, we're encouraged to use 4 cycles rather than 6 cycles. And the funding, the pharmaceutical companies will not allow us to extend the atezolizumab frequency from 3 weekly to 4 or 6 weekly. We've tried and they've refused. Mesothelioma, you will come across patients. So this is the last couple of minutes of the talk. You will come across a few patients a year. There have been no updates in several years. Just know for exam purposes that the only treatment that's proven to improve survival is pemetrexed cisplatin chemotherapy, and that improves overall survival from 9 months to 12 months. So it's just a 3-month benefit. But be aware of a number of trials that are going on across the country, looking at surgery, high throughput genetics, or novel treatments in the mesothelioma region. So if patients progress on the first line, I would consider referring them for trial rather than second line treatments if they're well. And just to finish up on thymoma, again, this is from ESMO 2015. There has been no updates in this sphere, but it's easy to sort of work out what you need to do. The way I remember it is just alphabetical, RST. If you work out what the R resection margin is, what the Masoka stage is, and what the tumor subtype is, and you literally have this in front of you, you can work out what to do with any patient. So for example, R0, stage 2B, B1, follow-up. They don't need post-operative radiotherapy. This is split into your thymomas and your thymic carcinomas, and the main difference is that all of the thymic carcinomas need post-operative radiotherapy, and most of them will get chemotherapy. However, none of the thymomas get chemotherapy. They are all either follow-up or post-operative radiotherapy. So I just threw that in there as a useful sort of reference to come back to in future. So in summary, we looked at the non-small cells, radical palliative, new and COVID. We looked at the small cells, nothing much for mesothelioma or thymoma, but hopefully that's just a bit of help when you're working at clinics and MDTs and things. So that's it from my side. Yeah.
Thank you, Waleed.